Sulfonylureas. These are oral anti-diabetic drugs. So pharmacokinetics: given orally, 90% plasma protein bind, metabolized in liver, excreted through kidney. Now coming to examples, the first generation sulfonylureas are tolbutamide, chlorpropamide, tolazamide. Coming to second generation sulfonylureas are glimepiride, glyburide, glipizide, glibenclamide. So these are the examples of sulfonylureas. And there is another class which is called as meglitinide analogs. These are also function same to the sulfonylureas. That means the mechanism of action is similar, but the structures are different. Examples are ripaglinide, metiglinide. Now coming to the mechanism of action, sulfonylureas bind to the sulfonylurea receptors on the pancreatic B cells. So in the picture you can see this blue color receptors on the pancreatic B cells. So this stops the efflux of potassium. That means it blocks the ATP sensitive potassium channels, leading to decreased efflux of potassium. So the potassium increases intracellularly. It causes the depolarization, which increases the calcium influx. That means calcium is also stopped from going out, leading to the calcium influx, right? It causes release of the insulin from the pancreatic B cell, degranulation of the insulin granules. So once we'll see this flowchart, the sulfonylureas bind to the sulfonylurea receptors on the pancreatic B cell, blocking the ATP sensitive potassium channels, leading to the decreased potassium conductance. It causes depolarization, which leads to increased calcium influx. There will be degranulation of the insulin granules, leading to the insulin releases from the pancreatic cell. Indicated in case of diabetic mellitus type 2, contraindicated in diabetic mellitus type 1, diabetic ketoacidosis, liver, renal, cardiac dysfunction, or if the person is hypersensitive to the sulfonamides, and also in case of pregnancy. Now coming to adverse drug reactions, unlike metformin, these drugs have high risk of hypoglycemia. Metformin, the advantage is it does not cause hypoglycemia, right? But these drugs, sulfonylureas, cause hypoglycemia. If the person skips the meals, the blood glucose falls. And if the person is taking these tablets and skipping the meals, then there will be high chance of hypoglycemia. And also if in case of severe exercises or overdosage of these drugs, this hypoglycemia can occur. So another drugs like phenylbutazone, ketonazole increases the duration of action of this sulfonylureas, leading to the toxicity of this drug. When the more amount of sulfonylureas is present in the body, it leads to the more hypoglycemia, and also it can cause weight gain, rashes, photosensitivity, and purpura. Now let's see the mechanism of action in short. It enhances the insulin secretion from the pancreatic beta cell, right? For these drugs to function, we must require a normal functioning beta cell that is present only in case of diabetes mellitus type 2. In case of diabetes mellitus type 1 and diabetic ketoacidosis, the beta cells are destroyed. So we cannot use these drugs in case of these two. This is about sulfonylureas.